Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to today's session on the gut microbiota and metabolic syndrome. Doctors, as you know, that gut microbiota was first discovered in 1680 by Antony von Ludwig, and since then a lot of research happened on that. But still, it's very fascinating on how microbiome is related to our metabolic syndrome, or how blood glucose from diet is associated with a bacteria. So on this topic, that our host Dr. Sanjay Kalra will enlighten us. Today's session is brought to you by Enerzal Zero. And before we move forward, I would like to give last week quiz winners: Dr. Sanjeev Puri from Hoshiarpur, Dr. Apurva Vishwas from Ramgarh, Dr. Anand Purandare from Mumbai, Dr. Ashutosh Das from Tumluk, and Dr. Satish Kumar Jain from Bangalore. So thank you so much for being the part of the quiz. Now I would like to introduce our own host, Dr. Sanjay Kalra, President-elect South Asian Federation of Endocrine Society. Sir, please give your views on the topic, the gut microbiota and metabolic syndrome. Thank you, sir.
Thank you, Ankur, and good evening, everybody. We'll be talking today about a different aspect of diabetes, about a different aspect of metabolic syndrome. And this is something that is very important. First of all, it is important because it impacts our health. Second, it is important because we don't know too much about this aspect of medicine. But third, most important, because we can actually make a change. If we learn about this, whatever little we know, we can make changes in our diet, in our lifestyle, in our drug therapy, and we can improve our health. Now, see, man has reached the moon. We send our rockets, our space craft throughout the solar system and beyond that as well. We actually know more about the moon and more about Mars than we know about our own body. And within our body, the one field that we know the least about is the gut microbiome. What does this mean? We know that we have a gut, we have the stomach, the small intestine, the large intestine. This contains lots and lots of bacteria. Actually, trillions of bacteria, trillions of bacteria. But we don't even know more than 1,000 of them. We do not even know the names of the bacteria, or we've not been able to culture them. These bacteria that inhabit our own colon. These bacteria are live beings. They live in us. They are part of us. And they encode around 3 million genes. Not only do they encode genes, so they are our second genotype. They also produce many small molecules. And these molecules have an important role in our homeostasis. So this gut microbiome is known as our second genotype. It is also known as our second nervous system because these small molecules that are produced by the gut bacteria, they act like neurotransmitters. One example is serotonin. And they are also our second endocrine system or metabolic system because they actually impact our metabolic and endocrine health in many ways. Because of this, if we have an optimal gut microbiome, happy bacteria in our gut, we will remain happy. If, however, there is dysbiosis for whatever reason, then not only do our gut microbes become unhappy, our gut becomes unhappy, we also become unhappy. These bacteria have got anti-inflammatory activity, they have got antioxidant activity, they also act as sources of vitamins or energy. They might help in pain relief, that is the neurotransmitters, and they also regulate the barrier function of the gut. So how can dysbiosis occur? It can occur in the short term. Maybe you eat any kind of food that you are not used to. That food causes tummy upset or diarrhea. Suddenly the bacteria will change. We take a long course of antibiotics. That will change the bacteria because the antibiotics will kill not only the bad bacteria, but also the good bacteria. Even when we take anaerobic drugs, like metronidazole, for example, they also kill the anaerobes. Dysbiosis can also occur if you uh, have helminthiasis or giardiasis. And also, when you take a treatment for helminthiasis or giardiasis, that also might cause dysbiosis. So, multiple reasons for dysbiosis are there. But one main reason that we usually forget is metabolic syndrome. Metabolic syndrome itself can cause dysbiosis, and the dysbiosis can cause metabolic syndrome. So, if you have dysbiosis or the wrong kind of bacteria in the gut, you can have malnutrition. You can have metabolic syndrome, including type 2 diabetes, cardiometabolic disease, NAFLD, and also mood disorders. Now, before we forget, let's talk about mood disorders. So, we all know that serotonin is a happy hormone, and the treatments, the psychotropic treatments that are given in depression, are SSRIs. They inhibit serotonin reuptake. But the maximum amount of serotonin that is produced in the body actually comes from the gut microbiome. So, if you want to increase serotonin level, the easiest way is to keep your bacteria happy, prevent them from depression. So, serotonin comes from the gut microbiome, and that can impact our mood. Now, actually, what happens in good health? In good health, usually we take a balanced diet. This balanced diet includes a lot of plant-based derivatives, which have got a lot of fibers. So, fiber is very important. This fiber enters the gut. It leads to gut motility. Make sure we don't get constipation. But everyone will say fiber is not a nutrient because fiber cannot be digested or absorbed by the human body. But the answer is no. Actually, fiber is a mega nutrient, not even macro, it is a mega nutrient because when it enters the gut, it gets fermented. And these polysaccharides that are created are actually used up by the microbes. So they are food for the microbiomes, for our symbiotic microbes. And these microbes are able to digest the fiber and convert it into what we call SCFA, short chain fatty acids. Short chain fatty acids. These short chain fatty acids have got a lot of endocrine properties. One short chain fatty acid is butyrate, very important. And what this does is it enters the gut uh, lining, stimulates the L cells, and then you get GLP-1. So we spend so much of time and energy giving DPP-4 inhibitors, giving GLP-1 RA. They have their place in practice and they must be used. But what are the easy ways of enhancing endogenous GLP-1? That is to take a high fiber diet so that you are able to give food to your microbiome, and that microbiome is able to create SCFA like butyrate and then stimulate GLP-1 RA. And once you have increase in GLP-1 RA, in GLP-1, not GLP-1 RA, sorry, once you have increase in GLP-1, then automatically you get better insulin sensitivity and you get more energy expenditure and you get euglycemia. Unfortunately, what is happening now is that we are moving from plant to a to an animal-based diet and from fiber-rich to a more processed diet. So it's very low in plant fibers now, the diet that we have. And what happens is because the microbiome doesn't get its food, what happens is all this processed fat, the processed food, the meat, that gets proteolized. It breaks down into small peptides, which break down further into various amino acids. And these amino acids change the microbiome of the gut. The gut bacteria, whichever ones they do their best and they use these amino acids, but they end up with different types of products like BCFAs or TMAO. And then these lead to metabolic endotoxemia and also to hyperglycemia. So, high fiber rich diet can be used as a prevention and also as an adjuvant therapy for metabolic syndrome, especially for diabetes, for dysglycemia. And these bacteria that are there in the gut taking care of us, we should take care of them because if we take care of them, finally we end up healthier. Now, how can we keep our gut microbiome happy? The simplest way is dietary manipulation. So, what can we use? Prebiotics and probiotics. Is there a difference? Yes. Probiotics are substances which contain live bacteria. Example would be yogurt, any food that is fermented, whether it is a fermented salad or even the batter that you use to make idli or to make dosa, that will also have probiotic. So these are bacteria. Prebiotics are the food for bacteria. So one example of a prebiotic would be fiber. If we can give the right prebiotics, fiber rich food, if we can give the right probiotics, probiotic supplements, and you have many available as capsules and in powder form, then you end up getting more of the happy or healthy bacteria like bifidobacterium, lactobacillus, Clostridium cluster 14A. These happy bacteria produce more short chain fatty acids, acetate, propionate, and especially butyrate. And what these do is they end up increasing GLP-1. You also have more insulin sensitivity, less appetite, and less adipogenesis. So you are able to prevent obesity, and if obesity has come in the picture, you are able to manage it. So what we should do is dietary manipulation, and two things we are coming into: more of prebiotics, more of probiotics. Now, how can we take this? One would be medical grade sources, the other one would be home cooked food. So in home cooked food, for prebiotics, high fiber. So take fiber rich vegetables. Probiotics, take fermented salads like kimchi and take curd. A single suggestion, I think, would be curd 250 or so grams 2 to 3 times a day. Medical grade, take a good quality mixture of prebiotic and probiotic. So if you want to take a powder form, just mix it in 50 ml or so of water and take it daily. And if we do this, both home cooked food and also including high fiber diet and also the medical grade prebiotic, probiotic if required, we will actually end up having better metabolic health. We will also end up having better weight management. And when we speak of weight management, you remember we speak of this frequently. Look at the meal pattern, the meal composition, the meal quantity, and the meal sequencing. But along with that, look at the meal for the microbiome. So increase the fiber content, and you might be able to get better results in obesity management. In diabetes, of course, this is important, and we would want to add butyrate. And the best way to do it is to increase prebiotic and probiotic intake. Your patients will ask you, why should I do that? So many other things you are asking me to do, why this as well? So you will tell them actually, when you take more of fiber, satiety increases. Also, the health of the GI lining increases of the colonocytes, the gut barrier. And within the blood, there is less oxidative stress, less inflammation, reduced aging, and also less of carcinogenesis. So, this is a simple way that we can use to help. Even for lipids, you will find that gut microbiome has an impact. People with dyslipidemia have low microbial diversity in the gut, so they have less number of bacteria. And people with normal lipid profile have high microbial diversity. We've already spoken of mood. And in the OPD, many times, earlier I used to laugh when patients used to come and say, Doc Sahab, gas hai, gas dimag ko chad rahi hai. I have gas in my stomach, which is going to my head. But now, actually, maybe it is the gut microbiome which is speaking and which is telling us or telling that patient that there is some kind of a disbalance in the serotonin production, in the there is some kind of a disbalance in the gut microbiome diversity. And that is why maybe the patient has got high blood pressure, which is manifesting as a headache in that particular patient. So these are a few things that we have to share. And as research is going on and on, we are finding more and more evidence linking the gut microbiome not only to diabetes, NAFLD, and obesity and dyslipidemia, but also to other downstream diseases like NAFLD. We also find evidence linking gut microbiome to immune disorders and to reduced immunity. So, with this, let's take our questions for today. Uh, Welcome to Dr. Vilas. Dr. Vilas says, should we prescribe PPI and OHA together? We can. For all the drugs, if you wish, you can. But ideally, PPI would be best taken 30 minutes before a meal, while most OHAs should be taken immediately before or immediately after a meal. So that difference is there. But otherwise, there is no issue. Of course, there is an issue for proton pump inhibitor and thyroxine. So that gap should be as much as possible, minimum 2 to 4 hours. So what you can do is try to maximize the gap, and thyroxine should get primacy. So give thyroxine first on an empty stomach and take the PPI as late as possible. Some patients may feel, they may say that I don't mind taking the PPI late at night, or I will take the thyroxine tablet late at night before going to bed. That's also fine. So you can put one at night and one in the morning. A bigger challenge comes when we are giving three drugs together. That is proton pump inhibitor, uh, tablet semaglutide, and thyroxine. Then semaglutide has to be given 30 to 60 minutes before a meal. You can give thyroxine maybe at 30 minutes gap. If at all semaglutide does something, if at all, it will increase the absorption of thyroxine, not reduce. It may increase. And the PPI can be given at night. There's another question. Does diabetes due to chronic pancreatitis, okay, pancreatic diabetes, or calcification of the pancreas, again, pancreatic diabetes, does it need co-prescription of digestive enzyme? Yes, it does. So we need pancreatic enzyme replacement. There are multiple drugs, and the dose comes in units, like 10,000 units. This is of lipase. So one drug which I use is Creon. Usually, I start with 10,000 units 3 times a day, given immediately before a meal. You can go up to 25,000 3 times a day. There are some people who remain very sick, and then eh, sometimes you will see in gastroenterology a dose like 25,000 units 3 times a day before the meal, and 10,000 units 3 times a day during or immediately after the meal. So, but the average dose would be 10 to 25,000 3 times a day before the meal, immediately before the meal. This actually helps, and it is not only limited to pancreatic diabetes. Even some patients with type 2 diabetes and even type 1 diabetes may have symptoms suggestive of exocrine pancreatic deficiency. So we use this drug. And one trade name is Creon, and it is pancreatic enzyme replacement, PER, that we are doing. Pain is also an issue in calcification of the pancreas. Patients come with repeated pain, and you will have to give painkillers. You may have to give an opioid painkiller as well sometimes. So, but do it carefully and do it for a very short period of time. Other questions, and we welcome Dr. Sanjeev Puri from Punjab, Dr. Geeta, and Dr. Anshul Singhai from Chhattisgarh. We also welcome Dr. Mohammad Sohail from Aurangabad in Maharashtra. And thank you for being with us, Dr. Dr. Pradeep Rawal from Ujjain, warm welcome, and also Dr. Nahida Tarannum. Welcome. And Dr. Tarannum also says, yes, fiber is a mega nutrient. Two mega nutrients that we have, one is fiber, the other one is water. And uh, we should not neglect these two mega nutrients. Also, greetings to Dr. Vinayak Sharma and Dr. Nitin Narula. Non-stop cough in nowadays season would be, if it is non-stop, it is allergic. So actually, Nitin, we should advise a pulmonary function test. You can suppress the cough, but it's a good idea to find out what the airway reactivity is. And if taking antibiotic aggravates it, then that means you should go to a pulmonologist, get a pulmonary function test. They will tell you what drugs are to be given, and if an inhaler is prescribed, they will teach you the right way of doing it. From Dr. Harshi Dingla, we have a question: teneligliptin or vildagliptin, which is better? So, vildagliptin has more evidence behind it. This I will say very confidently. Vildagliptin is a very safe drug to use. You can use 50 milligram twice a day. In some patients, 50 milligram once a day. And also 100 SR is available once a day. The only contraindication I can think of for vildagliptin is patient with severely elevated SGOTPT, severely elevated liver enzymes. But otherwise, the drug is safe from a cardiac point of view. It will not cause arrhythmia. And in patients with renal failure with CKD stage 3 or 4, you should use only 50 milligram OD, not BD. Teneligliptin doesn't have so much of data behind it, and especially there is a fear of increased QTC interval. However, the drug can be used in the same dose, 20 milligram OD or 40 milligram OD, in renal impairment as well. But overall, to answer it, the answer would be vildagliptin. It's nice to have Dr. Harshi Dhingra on the show because I happen to be married in a Dhingra family from Panipat in Haryana. So it's a good feeling. And also, good evening to Dr. Gauri Shankar Dharmaraj. We've been speaking today about uh, metabolic syndrome and the gut microbiome. So, we mentioned that the gut microbiome is very important. It is our second genome, it is our second nervous system, it is our second endocrine and metabolic system. And if we keep it happy, then it will keep us happy. The simple ways of keeping it happy are to ensure that we take adequate prebiotic and probiotics in our diet. If required, we supplement with pharmacological measures. Secondly, we avoid using unnecessary drugs, like, for example, antibiotics, which Dr. Narula said, or using maybe uh, unnecessary antibiotics and also unnecessary PPIs, which might impact the gut microbiome. One question is for diabetic constipation and diarrhea. Now, both of these are neuropathies, autonomic neuropathies, microvascular complications. So the first is look for other microvascular complications, nephropathy and retinopathy. Secondly, give good glucose control. Thirdly, avoid drugs which cause constipation or diarrhea. For example, iron, calcium, both of them impact the gut. So first fix the symptoms, then you begin giving iron, calcium. You can give vitamin D if you wish. Uh, for diabetic diarrhea, antibiotic, Dr. Gauri Shankar is asking. So yes, we can give doxycycline, 100 milligram BD for 2 days, and then 100 milligram OD for 19 days. Or we can give erythromycin, 250 milligram TDS for around 2 weeks. In diabetic diarrhea, uh, uh, motility reducing drugs like lumofen, for example, they can be used for a short period of time. And of course, the drugs, the probiotics, prebiotics will be very important. In diabetic constipation, we have to make sure that what we don't give very rapid acting insulin 30 minutes before a meal because the food won't get absorbed very easily. So if your patient is on insulin, you might want to give the injection after the meal. Uh, Apart from all the routine symptomatic treatment that you will use, other treatments will be high fiber diet and itopride 50 milligram 3 times a day, 30 minutes before meals. Another question is about the best gliptin. So it depends upon the patient choice. Now, let us say we have a patient with chronic kidney disease, stage 5, then linagliptin is the drug of choice. If you want CV safety, then sitagliptin, uh, linagliptin, both are equally good. If you want renal safety, then all are equally good. But all said and done, maybe I would vote for linagliptin because you don't have to change doses. It's a single dose that you prescribe, 5 milligram OD, and you don't have to worry too much about any other reports. The metabolics, okay, Dr. Manan Mehta from Mumbai. This is a very nice name and a nice thing, Manan. Metabolics, that's good. Question is any use of regular probiotics and any bacterial group we should target? Well, nothing specific. A balanced diet would work. My single advice would be curd, yogurt. Encourage your patients to take more curd. If they can't take curd, lassi, buttermilk, charge, that should also do the trick. Good evening to Dr. Hemant as well. And from Dr. Dharmaraj, how long we can give pantoprazole or rabiprazole? So you can give indefinitely. You can, but there are side effects. So if the patient has symptoms only, then we give. So some of the side effects are it might cause dysbiosis. It also can sometimes, though usually it is associated with levosulfuride, sometimes you can have high prolactin levels. So if patient is taking and patient is happy, fine. How you can reduce the overall dose? You can tell the patient you take only as and when required when you have symptoms, and you explain about diet. Reduce the following S's: reduce spice, smoking, reduce salt. So reduce hot drinks like taking very hot beverages like tea or coffee. They can cool them down before taking. By doing this, they might be able to reduce the total requirement of pantoprazole or rabeprazole over months or weeks. Another drug that you can use is if you want to avoid using the prazoles, uh, it's called the trade name is Ribagen, I think ribamimide. So that you can use 100 milligram twice a day. It is a cytoprotective drug. And Dr. Shivam says if metformin causes constipation, which oral drug should be prescribed? Reduce the dose of metformin. Change the formulation. If patient is taking SR, change to immediate release. If patient is taking immediate release, change to SR and reduce the total requirement. If still you are not able to manage, one good drug you can prescribe is imeglimin, 500 milligram BD or 1000 BD. So 1000 BD is the dose for most people, but if the EGFR is below 45, then 500 milligram BD. One question on ED we have discussed many times in this group, and we will do it again in the coming months. ED is common in diabetics, even if glucose levels are normal, because there are so many factors: blood pressure, cholesterol, mood, so many things are there. So that we have discussed in the past as well, and we can discuss later on. And another question is from Dr. Ashutosh Das. How long we can use pre and probiotics? So we can use indefinitely. Indefinitely means indefinitely. What is the side effect? None. And how do you monitor? You monitor with well-being and with other metabolic parameters. So whatever you set out to do, you wanted good health, good mood, weight control, whatever it is that you are aiming to do, you do that. But you can take indefinitely. And Dr. Sanjay Shihora says, is it okay to take high fiber diet regularly, even as being healthy? Yes, it is, because that will actually keep you healthy in future as well. So it's good to take it for prevention. If you're taking a normal Indian diet with enough vegetables and fruits, then the fiber should be adequate. We don't need to count separately, and we don't need to take a fiber supplement. A normal Indian diet will contain adequate fiber. If you take whole vegetables, whole fruits, uh, that should suffice actually. Another point question from Dr. Manan Mehta, role of regular probiotic supplements. So yes, if your patient has got GI disturbance, frequent GI disturbance, mood disturbance, and patient has symptoms related to the GI all the time. Like I said, the patient comes and says, "कि gas दिमाग को चढ़ती है." So you are giving a proton pump inhibitor, but still it's not working. Maybe the patient has diabetic gastroparesis, but then maybe the patient has dysbiosis of the gut microbiome. So then we can use them. When do I use probiotics proactively? When patient has got diarrhea, patient needs is in convalescence stage after any kind of illness, patient has received antibiotics for a long period of time, or we think that we have to give antibiotics for a long period of time. Maybe patient has got diabetic foot. It's in these patients that I use probiotics. So lots and lots of questions coming up, and another question was severe painful burning feet. So this also we have discussed many times in the past, painful neuropathy, and I'm sure you'll be able to find the link to the Diabetes Essentials episode regarding this. This question from Dr. Gauri Shankar. Oh, okay, now I got it. So patient has got very severe neuropathy, 35 years old on insulin, HbA1c is 8.4. He had an injury and he didn't even realize it. He had bleeding, he didn't realize because there was no sensation. So that means severe neuropathy. So glycemic optimization, nutritional optimization. Control glucose with insulin. If patient is on pre-mixed, you shift to basal bolus for some time. Nutritional optimization, micronutrients. especially vitamin B, vitamin D. Third is prevention, orthotic optimization. So make sure the patient wears footwear which prevents him from getting more injury. So these are the three things to do. One more question. This is from Dr. Saurav Chaudhary, 51-year-old lady having evening time heaviness of abdomen. Yeah. So this is quite common in the OPD. It might be because of the lunch. So the first thing is you modulate the lunch because she has this problem in the evening. So you tell her, Madam, what did you have for lunch? Let's reduce the fat contentancy. Let's reduce the carbohydrate contentancy. Let's change. Let's give more fiber. Let's give less fiber. Let's see what happens. Why don't you have a cup of tea at the same time? So this is uh, nutritional optimization or modulation. Whatever food you are having at lunchtime, why don't you break it into two? Instead of two chapatis, you have one chapati at lunch, and then you can have one chapati 2 or 3 hours later. So focus on that. Spend time taking a history, and you can tell the patient, Madam, the etiology is in your kitchen, and the treatment is also in your kitchen. So I'm very sure you'll find the answer to it. Until you have found the answer, why don't we give you a drug at lunchtime? So then you can give proton pump inhibitor with domperidone or with itopride. This is one thing that can be done. Second thing is I forget the name. Rivagen is the trade name. That can also be given with lunch. The Some patients will say, I don't want treatment, you give me some over the counter preparation. So then we advise them to take a pinch of baking soda after lunch, 1 or 2 hours after lunch. You just take 50 grams or 50 ml of water, and maybe half a pinch or one pinch, just a pinch, maybe up as much as your nail, that much of baking soda, and that will help. Also do pharmacological optimization. Look at the other drugs that the patient is taking, maybe iron, calcium, an antibiotic. And just see maybe some OTC multivitamin, and try to stop those. Here, prebiotics will actually help. So a powdered preparation of a pre and probiotic mixture might actually help this patient. Yeah, thanks, Mr. Basu. Ribamipide. I have always found it difficult to pronounce this. Ribamipide, 100 milligram BD is the dose, and this actually helps. So with this, I'd like to thank everyone for having joined us today. We'll be continuing with diabetes essentials over the coming months. We have a couple of interesting topics coming up, and then we'll spend 2 weeks talking about pre-Ramadan education. And after that, we'll continue with a fresh season 3 of Diabetes Essentials. So once again, thanks to everyone, and I'll hand over back to Team FDC.
Sir, one more question is there of Dr. Gauri Shankar Dharmaraj. Sucralfate or Semithicone or Megaltrate? What is the
Yeah.
difference and how patients to give, sir? What patients to
So
give, sir?
there is a difference. If the patient is complaining of gaseous distension, gas है, पेट फूल रहा है, distension, then simethicone. If the patient is complaining of pain, burning, acidity, then sucralfate or megaltrate. Sucralfate has relatively less side effects, actually none, except that it may reduce the absorption of thyroxine and some other drugs. Megaltrate has got magnesium, and in some patients with chronic kidney disease, especially end-stage kidney disease, you may have to look at magnesium levels. Otherwise, simethicone versus sucralfate. Simethicone for those with gaseous distension, sucralfate for those with burning pain.
Obviously, sir, Semithicone is like an adsorbent like charcoal, and Megaltrate and Sucralfate covers the ulcers better. So, sir, thank you very much for taking, as usual, all the questions, even late questions. Also, sir, I am very thankful to you that you keep on taking the questions till a last questions has been available. We are very thankful to Dr. Sanjay Kalra for almost completing the session 2 of Diabetes Essential. 52 weeks. We are now nearing completion. However, we will be having 4 mega sessions during the Ramadan entire month, as sir has already announced. Last time also we have discussed in this session that this will help all the population who are ritually practicing this holy month. and we find difficulty in our what we say daily OPD in terms of treating them and at the same time having keeping faith on their religions. And that's the wonderful session we will be coming up with next 4 weeks in the month of March. Obviously, sir has also announced that we will be continuing this Diabetes Essential Season 3 for the next 52 weeks, so that all the questions which we all are facing during our OPDs, whether it's from a field of medicine or diabetes or related to that, at the talk we get at the Sunday, we have our savior, Dr. Sanjay Kalra, to answer all the questions till the end. He is very patient in terms of his tolerance levels, in terms of questions, repeated or non-repeated, previous question, new questions, all he takes it for us, and we are very much thankful for him, sir. Thank you, Dr. Sanjay Kalra, for being with us and taking today the uncharted waters of gut microbiome, because as you have already discussed during the session, that a lot to be known about the 3 trillion or 4 trillion, I don't know the exact number also that way, gut microbiome and their roles. We are still, it's been called uncharted water of gastroenterology. Thank you very much, sir, for taking it from the perspective of diabetes surgeons. With this, I
Thank you.
thank sincerely Sir Dr. Sanjay Kalra. Good night, sir, and Jai Hind, sir.
Jai Hind.